Thank you so much for the introduction, and it's a pleasure to be here again today. And I will be talking about the AI-enhanced surgical ecosystem. These are my disclosure, but most of the research that I will be talking about today, it's academic research at Ghent University, and I have no financial conflict of interest. To start with the operating of the future, I would like to think about what it was operation in the past, where are we now, and what we are hoping to go in the future. So in the past, we had a simple relationship with the patient. There was with the instrument, metal or wooden instrument that we had, and we were operating on the patient. There was no recording, no collection of the data, and it was only surgery being done. Nowadays, we are doing device-enabled surgery. We have laparoscopy, we have robot, and actually we are operating on the patient with having a device between us and and the patient. By that, of course, we got, especially with the robots, a lot of precision in our hand. It helps us to remove actually the tremor, and give us more dexterity. We can get to a lot of things that we couldn't do before. Now a robot is really a tool that enables our hand to do much better. But what we are hoping to do in future is to have data-enabled surgery. And by that, I mean, we hope that we can have a better perception of what is going on in the OR, and with having the data available at the time, hopefully we can have enhance our mind as well as our hands in the OR. And why is that important? Because there is actually a sad data in the literature, and it is coming up still with all the precision that is happening, that 3 to 5% of surgical patients suffer from complication. And sadly, more than 75% of that complication is on us. It's technical related complication, and it could be hopefully prevented if we can do better in the OR. And I believe that with all the technology that we do have, it's not about being able to do the surgery, but it's more about the concept of the surgery that we have in the OR, and the judgment relapse and the problem that happens during the surgery, that we can't fully understand the disease, and that's where the thing mostly goes wrong. So it's important to say that I think you all would also agree that surgery is actually one of the most insightful acts that a human being is doing. It includes knowledge, skills, empathy, and actually it's all come together in one moment. And as we are moving into the era of having data-enabled surgery, those insights are no longer limited to surgeon's hand or surgeon's experience, and it's about what is going on during the operating room, and it's not only the surgeon but also the environment around. So with this introduction, I would like to give you some examples that already exist, some things that we are working on for future, and how we can have this AI not as something, as a fiction in our dreams, but in our hand to be using it in a normal way. So this is actually, the study is old, but still I think so far is the most beautiful demonstration of how we can use AI for a surgical guidance. It's a study being done by the University of Toronto and San Francisco, and what they have done, they have actually trained a model that can show the places of safe dissection during the cholecystectomy. So you can see that the red part of the screen shows the safe dissection plane for a cholecystectomy. Means that if you are doing the surgery in that plane, you are safe, and if you go above or below, you are not. And to better understand the importance of that, I want to show you this nightmare surgery of bile duct injury that is happening. Of course, it's retrospectively shown to the system. And you can see the surgeon is dissecting below the safe zone that are being mentioned you can do safely, and eventually putting the clip and cutting the common bile duct. And that's actually something that we hope in the future of the OR, I think probably a lot of you would say today also is not happening, but I'm not sure that this is not happening. And I think that exists in a lot of places that don't have access to the care that people would deserve, and still there are surgeons out there that can do this, and hopefully if we can have some kind of AI model that is available in the OR, we would not have these basic mistakes in our surgical department. So to have, of course, we hope that using AI will bring us to do a better thing and do it in a more accurate way. An example that I want to give you is that when we are dealing with the oncologic patient, it's very important to know the tumor load in the abdominal cavity. We do it most nowadays subjectively using the PCI. I say it's subjective, it's a number, but it's still subjective because the surgeon looks at the image and say, okay, for me it's less than 5 centimeter, more than 5 centimeter, and gives a number on it. But this can be done in a better way and in a more accurate way. And this is actually a tumor detection model that we have developed and has been also published, that you can have the laparoscopic camera going around, and basically what you are seeing is that during the exploration, we recognize the abdominal cavity, that organs that are visible in the picture, as well as peritoneal metastasis. And the numbers that are coming up there are actually the probability of that lesion being a tumoral lesion. And as you can see, we have compared the performance of the model with the performance of the surgical oncologists at Ghent University Hospital that, believe me, they are experienced in what they are doing. But in this comparison, you can see that the machine learning model is outperforming the prediction of the surgeon in predicting whether a lesion in the abdominal cavity is benign or malignant. To go further with that, actually, we would like to not only know is it malignant or is it benign, but if it's malignant, can we have a measurement out of it and do that PCI scoring in a more objective way? So in this image, you can see there is a small bowel with a actually tumoral lesion on the small bowel, and above in the top we have a segmentation model, so the computer shows that there is a bowel, there is an instrument, and there is also metastasis lesion on the bowel. That's all being segmented in green. And then below is the depth estimation model. Actually, if you bring in and out the camera, you can have a difference in the size depending on the distance of the camera from the object that you are looking at. And with that depth estimation model and knowing the standard measurement of the laparoscopic instrument, we can make an accurate estimation of the size of the tumor that exists in the thing. And that's the instant thing that the computer does the calculation, and there is no need for a mental process out of it. And by collecting that, we can eventually have the whole tumor burden in the abdominal cavity, which is way more objective than having the PCI calculation. This is actually this model in action, if I can play the video, but no, it doesn't work. It shows that all these 3 different models at the same time are working, and when the three of them are working together, we can have the detection of the model, we can have the calculation of it, and we can have the finally the calculation of the PCI of the tumor. And this is actually a PhD work done by the pictures that you are seeing are brilliant PhD students that are working hardly in our lab doing this research. But as you can see, the machine learning model was performing well, but we are still want something to be more precise, because it's only at that machine learning model that detects the tumor, basically computer sees what we see and we get the information. But can we have a computer who sees the things that we don't see? And the answer for that is yes. We do have, normally in laparoscopy, we use what it calls RGB cameras, in robotic as well. And with that, RGB, as you can see in the picture, means that we are having the three spectrum of the light, red, blue, and green. But of course, we know that the spectrum can be way more than that, and that's where the hyperspectral or multispectral imaging is coming in. And it's an advanced imaging technique that captures many narrow bands of the light, and it's far more than the three that used in the normal RGB cameras. And then with each pixel of the hyperspectral imaging comes details of the light spectrum, can give us an insight about the composition of that tissue. And this is something that the RGB cameras so far never could have done it. And now we are hoping that with having this advanced imaging in our operating room, we can see better how it's being done. This is, of course, it's exploratory research, not published yet, but I would like to show you some example of it. As you can see in this picture, this is the hyperspectral camera, can be loaded on the normal laparoscopic camera here, and the setup is very straightforward, like just a laparoscopy. You look into the picture, and this yellow and red image that you can see here, it's the hyperspectral imaging there, and you can appreciate that there is a huge difference between what we are seeing in RGB and what we are seeing in the hyperspectral imaging. And in the numerical way, there is a huge difference in the composition of the tissue of tumor versus the peritoneal. This is actually the same hyperspectral imaging. It's an image of a neuroendocrine tumor of the pancreas. The tumor, of course, is not visible in the RGB camera, but at the right, that yellow spot that you are seeing there, it's showing the tumor. So this is, of course, the tumor in the distal pancreas. Probably it doesn't make a lot of sense to have extra information, but imagine if you have this tumor at the neck of the pancreas and you have to decide, shall I do the Ripple or distal pancreatectomy? This kind of information would be very valuable to have. I think Andrew talked a lot about augmented reality, and from the question that he asked, that does anyone has augmented reality being used, the answer in most of the places is no, and the reason for that is that we basically still don't have solved the mathematic registration problem that is going on, and the superimposing of the preoperative imaging on the abdominal cavity, especially for the organ like liver that is moving, is a very difficult thing. Actually, sorry, I am just... actually, if we want to look at it, it was also in the conclusion of the slides of Andrew that I'm happy he also thought of the same thing, came to the same conclusion, that we should go back and look into the video analysis. And if we want to, instead of, because so far all the research in this phase has been to look into the 3D models and trying to make our 3D models more smart. But I think with artificial intelligence, we have the chance to look at our 3D videos instead of looking at 3D models and looking what is happening during the surgery in a 3D and try to actually make a conclusion out of the view that we see in surgery. So here I want to show you a 3D reconstruction of the actually 2D video of the liver surgery that we have. There is the technology that artificial intelligence can look at every 2D image and make a 3D reconstruction when you are looking at it from different angle. And in the end, when you are having the camera moving around and seeing that, then you can have a 3D model of the image of the liver during the surgery. And this is the information if we fit to the preoperative CT scan that we had, and if we have the combination of these two data, hopefully we can solve that problem of registration and we can have the liver being automatically superimposed on the abdominal cavity and giving us more information. But here probably it's something that I a bit disagree with what we heard from Andrew, because he was just talking about the, using the robot and surgeon both being at the bedside and trying to make that distance from the console to the bedside and removing that. But we do a lot of research on telesurgery, and well, of course, telesurgery is not anymore a research phase. It's being done and it's being approved, and it's something that now in a lot of countries happening nowadays, that people are operating from the west to east and vice versa, so it's not anymore a new concept. But what is important that, of course, we don't want to have surgeons being as far as away, but probably in future, if we have this in a more logic and in a more human way of using telesurgery, we can bring a lot of advantage for mentorship, for training, and also for intraoperative guidance during surgery by having experienced surgeon just logging in from distance and giving a tip during the difficult phase of the surgery, and just the rest can go as normal as it is. And I see a lot of potential for telesurgery. The research in telesurgery is more about the latency, and by latency is actually, there is a lot of technology around that affect the latency, and means that when we are doing an act using the console, the translation of that act to the patient, how many seconds that will take, and that makes a lot of actually difference in the way that we are delivering the care. So from one side, the medtech companies are trying to keep that latency as less as possible and as stable as possible, so we as a surgeon can operate without even feeling that there is a few second delay, not second, of course millisecond delay of what we are doing and what is happening for the patient. And on the other hand, as surgeons, I think it would be our responsibility to define that and to say if there is this 20 millisecond becoming 30 or 40, then we should not use that and have a continuous monitoring of that. And this is the research that actually we are doing on telesurgery to see if we can put a definition on the latency that is acceptable for training, for minor surgery and for major surgeries, and that should be a different latency for each of them. I think in the future, surgical AI and clinical decision-making, we probably must think beyond just a single data source, which is mostly now only CT scan or some preoperative imaging. We need to think about more of a AI as a whole of the spectrum of the things that we can use in the OR and also in the preoperative and postoperative. If you are interested in surgical AI, we do have our Congress for Surgical AI in February being organized at Ghent by Orsi Academy, and we would be very happy to host you there. There will be a lot of of innovation in the field that being presented there. Thank you so much for your attention, and I'm happy to answer questions.